Welcome to Roadmap to Residency. Hello everyone, I am Aviraz. Welcome to our Club 250 Matchmaker sessions. We are currently in our neurology module and we will be running through some questions with you guys to help you on a journey to a 250. So question number one, the patient most likely suffers from which of the following conditions? A 65-year-old woman is brought to the clinic by her husband due to worsening memory problems. She has a medical history significant for long-standing hypertension, type 2 diabetes mellitus, and depression. Physical examination shows cognitive impairment but no focal neurological deficits. 2 years later, the patient suddenly dies from a massive myocardial infarction. Congo red staining of brain samples obtained from the hippocampus and cerebral arterioles reveals patchy red deposits that turn yellow-green under polarized light. This patient most likely suffer from which of the following condition? Alzheimer disease, Huntington disease, Parkinson's disease, Pick disease, pseudodementia, vascular dementia, or vitamin B12 deficiency. So amyloid is an abnormally folded fibrillar protein that deposits in the extracellular space of tissues. When stained with Congo red and viewed from under polarized light, these deposits have a characteristic apple-green birefringence due to their beta seed structure. Amyloid deposition can affect multiple organ systems, as occurs with plasma cell tumors, amyloid light chain protein, and chronic inflammatory diseases. However, in Alzheimer's disease, amyloid deposits are seen exclusively in brain tissue, and these deposits contain beta amyloid, which is informed by cleavage of amyloid precursor protein. Now, only in the disease, neuritic senile plaques can be found in the medial temporal lobe, example hippocampus, like in our patient, and are composed of central A beta core surrounded by dystrophic neurites. A beta deposition also occurs in the media adventitia of cerebral vessels and may cause vessel weakening with intracranial hemorrhage. Now, this is the histological pictures of the amyloid and Alzheimer's disease. So here we can see this amorphous eosinophilic material is the amyloid, which is the abnormal folded proteins, and these are the blood vessel walls, which are deposed, and these blood vessel walls contain the huge amount of amyloid deposition. And under apple green, under Congo red stain and polarized light, it shows apple green birefringes. You can see these green materials here, and these all green materials here all are amyloid bodies, and this is the blood vessel lumen, and this is the blood vessel wall, and this blood vessel wall contains the amyloid, and this actually narrows the blood vessel lumen and can predispose the patient to stroke. Now, also here in the Alzheimer disease, we can see the neuritic plaques which are seen in the Alzheimer disease. So this is the typical picture. Very similar picture appears also in the real exam of the USMLE step 1. Choice B, or the Huntington disease, typically presents with dementia, coriform movements, dystonia, and psychiatric symptoms. Patients typically have atrophy of the choroid, and microscopy reveals intranuclear inclusions containing aggregates of Huntington protein. Parkinson's disease usually presents with bradykinesia, rigidity, and tremor. Brain biopsy characteristically shows intracellular eosinophilic inclusions composed of alpha-synuclein Lewy bodies. Pick disease, frontotemporal dementia, typically presents with changes in the personality, behavior, and abnormal speech. Example, aphasia. Individuals usually have pronounced frontotemporal brain atrophy, and silver staining shows around cytoplasmic and inclusions containing aggregates of tau protein. So this tau protein or pig bodies are characteristic of pig disease. Elderly individuals may develop cognitive impairment in association with depression, pseudodementia. However, neuritic plaques and amyloid angiopathy would not be seen. In case of vascular dementia, typically presents with sudden stepwise cognitive decline in the patients with cardiovascular risk factors and ischemic stroke. The absence of glial scar formation on autopsy makes vascular dementia less likely in this patient. Vitamin B12 deficiency is common in the elderly and may cause dementia, peripheral neuropathy, and or subacute combined degeneration. 72-year-old woman comes to the office for a routine follow-up visit accompanied by her son. The patient has experienced progressive memory loss over the last 2 years. She now needs help with her daily activities such as shopping and housekeeping. Here we can see the patient has progressive memory loss. The patient's son says he used to be such an independent person, but now she needs help with most of the things. She even forgot my name the other day. You can see the patient is having gradual decline in the memory and function. Medical history includes hypertension, hyperlipidemia, and type 2 diabetes mellitus. Family history includes major depressive disorder in her father. MRI reveals diffuse cortical and hippocampal atrophy. Which of the following biochemical changes is most likely contributing to this patient's condition? Decreased choline acetyl transferase activity in the nucleus basalis, decreased dopa decarboxylase activity in the substantia nigra, decreased tryptophan hydroxylase activity in the raphe nuclei, increased acetylcholine esterase activity in the caudate nucleus, increased dopamine beta hydroxylase activity in the locus coeruleus. So the patient is having Alzheimer's disease. So in Alzheimer's disease, the patient have anterograde memory loss, that is immediate recall affected and distant memories are preserved. Visuospatial deficits, example, lost in the own neighborhood, language difficulties, cognitive impairment with progressive decline. Late findings include neuropsychiatric, like hallucinations, wandering, sometimes question mavens about hallucinations. Dyspraxia, example, difficulty performing learned motor tasks, lack of insight regarding deficits, and non-cognitive neurological deficits. And the patient may also have other symptoms like urinary and fecal incontinence. So Alzheimer's disease is the most common cause of dementia, and it has the following characteristic features. Prevailing clinical symptoms: slow progressive memory loss, macroscopic brain appearance, mild to moderate generalized brain atrophy, macroscopic brain changes like neurofibrillary tangles, senile plaques, and amyloid angiopathy. Some other biochemical abnormalities like decreased acetylcholine levels in the hippocampus and nucleus basalis of Maynard. The most important biochemical abnormality noted in Alzheimer's disease is a decrease in the acetylcholine level. And this occurs due to a deficiency of choline acetyltransferase. And the decline in acetylcholine is most notable in the nucleus basalis of Maynard, which participates in memory and cognition. Now, this nucleus is located in the base of the forebrain and widely projects to the neocortex. Now, another involved structure is the hippocampus, which is the major function structure for the formation of new memories. Now, symptomatic management of AD includes cholinesterase inhibitors, which target the acetylcholine deficit by inhibiting the degradation of acetylcholine in the synaptic cleft. So loss of dopaminergic neuron is seen in Parkinson's disease and dementia with Lewy bodies. The raphe nuclei from the medial part of the brain stems reticular formation. Many neurons in the nuclei are serotonergic, and serotonin is implicated in pathogenesis of anorexia, depression, and sleep disorders, not in Alzheimer's. Atrophy of the caudate nucleus is seen in Huntington disease, and the locus coeruleus is thought to play a role in the pathogenesis of panic attacks and panic disorder. Now, it is located in the pons and contains cell bodies of noradrenergic neurons that synthesize norepinephrine. So, Alzheimer's disease is characterized by the decreased level of acetylcholine in the nucleus basalis of Maynard and the hippocampus, which is caused by the diminished activity of the cholinesterase. Now, let's move on to next question here. So, this patient is most likely has a condition that predominantly involves which of the following structures? A 54-year-old man is brought to the office by his daughter. She says that her father has been acting strangely over the past 2 years. He makes inappropriate sexual jokes, has little regard of social rules, is often irritable, and is borderline aggressive at times. Now, the patient denies that his personality is any different from the normal. And when speaking with the patient, the physician notices that he has minimal verbal output and repeats, "It is what it is," and when asked questions about his strange behavior. On physical examination, he appears unkempt or otherwise has no significant findings. Now, this patient most likely has a condition that predominantly involves which of the following structures. And we can see the patient is mainly having behavioral disturbances, and the patient is not guilty about anything at all about his behavior. So, which of the following structures may be involved? Anterior temporal and prefrontal cortices, caudate nucleus, and putamen, locus coeruleus, and substantia nigra, mammillary bodies, and medial thalamus, medial temporal and parietal cortices, parietal and occipital cortices. Now, these sort of patients generally, uh, I will tell you the diagnosis in the next slide. But you can see that this patient is having no insight about his change in the behavior. The patient is not having any regret at all. And mainly, these sort of questions with this diagnosis tells you that the patient is having, it's showing some sort of behavior that is sexually inappropriate. So, what are the difference of diagnosis of different dementia subtypes? So, Alzheimer disease, which is the early insidious short-term memory loss, language deficits, and spatial disorientation. And later, the patient may have personality changes. So, vascular dementia is stepwise decline, early executive dysfunction, and cerebral infarction, and or deep white matter changes in neuroimaging. Frontotemporal dementia, early personality changes, apathy, disinhibition, and compulsive behavior, frontotemporal atrophy or neuroimaging. Dementia with Lewy bodies shows visual hallucinations. So hallucinations is a very important part of dementia with Lewy bodies. And we again have spontaneous Parkinsonism, fluctuating cognition, rapid eye movement, behavior disorder. Another thing is normal pressure hydrocephalus, which shows ataxia or lane disease, urinary incontinence, and dilated ventricles on neuroimaging. Prion disease, which shows behavioral changes, rapid progression, myoclonus, and or seizures. So this patient was having frontotemporal dementia, where the patient generally has prominent frontal lobe atrophy, as shown in this MRI. This is the normal, this is the affected MRI. Again, this is normal brain MRI, and here you can see frontal lobe atrophy in large CSF space and temporal lobe atrophy, and increased prominence of Sylvian fissure due to the temporal lobe atrophy. So frontotemporal dementia, frontal and temporal parts are affected. Frontal lobe or frontal part centrally decides our behavior and cognition and all, behavior towards people, our personality. So if frontal lobe is all involved, then the patient will be having some behavioral changes like in frontotemporal dementia. So this patient's personality and behavioral changes, example, disinhibition, apathy, social inappropriateness, compulsive behaviors, and altered speech patterns are consistent with the diagnosis of behavioral variant frontotemporal dementia. Personality and behavioral changes present early in the pre-course with neurocognitive deficits occurring later. FTD is highly heritable and a common cause of early onset dementia, and it is characterized by the initial degeneration of the prefrontal cortex and eventually progresses to include the anterior temporal cortex. The loss of junction in the prefrontal cortex can cause inappropriate behavior, impaired judgment, and poor problem-solving skills. Example, executive dysfunction. Here in this image, you can see that the patient is having frontal as well as temporal dementia. If the patient is having involvement of frontal lobe, then he will have behavioral changes. And if the patient is having temporal lobe involvement, then he will have apathy. Okay, like the patient is saying, it is what it is. He does not care anything. He thinks that everything that he does is right. He doesn't have no apathy, no emotion at all. So this means that the patient is having involvement of the frontal and temporal lobe. And along with dementia, we can see that the patient is having frontotemporal dementia. So the caudate nucleus and putamen are basically ganglia structures that together form the dorsal striatum, which regulates the voluntary movements. Huntington disease causes atrophy of the dorsal striatum and presents with coriform movements, psychiatric symptoms, and dementia. And these patients' prominent personality changes and lack of a movement disorder are not characteristic of Huntington disease. The neuronal loss in the nucleus ceruleus and substantia nigra is seen in the Parkinson's disease, which is typically presented with tremor, bradykinesia, and rigidity. The locus ceruleus is a protein structure that is one of the primary areas of norepinephrine synthesis in the brain. And the substantia nigra, located in the midbrain, contains dopaminergic neurons whose axons project to the striatum and participate in regulation of voluntary movements. Damage to the mammillary bodies and medial thalamus is characteristic of chronic Wernicke encephalopathy and Korsakoff syndrome. Both disorders result from the chronic thiamine deficiency and most often in the context of heavy alcohol use. So medial temporal and parietal cortical atrophy is characteristic of Alzheimer disease, and disproportionate atrophy of the parietal and occipital cortices is seen in posterior cortical atrophy, which is an atypical variant of Alzheimer disease with prominent visual symptoms. Let's talk about one more question here. So which of the following adverse effects is most likely to persist despite adding carbidopa to this patient's treatment regimen? A 65-year-old woman comes to the office due to progressive difficulty with walking for the past year. In addition, the patient has difficulty lifting her right leg to get into and out of the car, getting dressed using the right arm, turning over in bed, and peeling vegetables, especially with right hand. Examination shows lack of facial expression, cognitive rigidity in all extremities, a shuffling gait, and a fine resting tremor of the right hand. In addition to levodopa, carbidopa is also started, mainly to reduce the severity of the adverse effects of the levodopa. Which of the following adverse effect is most likely to persist despite adding carbidopa to the patient's current treatment regimen? Anxiety and agitation, hot flashes, nausea and vomiting, postural hypertension, or tachyarrhythmias. So let's talk about the normal basal ganglia motor pathways. So this is a very important figure for the USMLE step 1 examination. So let's see what happens. So the dopaminergic neurons in the substantia nigra maintain baseline inhibition of striatum. Okay, it generally inhibits the striatum. So the subthalamic nuclei and globus pallidus internus regulate the thalamus activation, right? And the thalamus controls the motor cortex activation. So you need to inhibit the thalamus to inhibit the uh, motor control, right? So all the pathways that are in red are the inhibitory pathway, and all the pathways that are in blue are the excitatory pathway. So the substantia nigra, okay, it inhibits the putamen on a striatum, okay, or striatum. And this, if the striatum is inhibited, then it cannot inhibit the, like, you inhibited the function of the striatum, whose function was to inhibit the globus pallidus externus, okay. Now, if you cannot inhibit the globus pallidus externus, then it can trigger globus pallidus internus, okay. Also, the substantia, the subthalamic nuclei, it again has a stimulating factor of globus pallidus internus. Now, the function of globus pallidus internus is that it can cause inhibition of the thalamus. And thalamus, when it is inhibited, there is no movement, right? Now, whenever there is defect in this pathway, okay, then you just have a very exaggerated mm, inhibition of the movement. And that is what is disorder in case of Parkinson's disease, guys. So this is a rather important figure which tells that whenever there is imbalance in the inhibition and activation of the excitatory pathway or inhibitory pathway, then that will lead to the Parkinson's disease development. So what are the mechanisms of action for Parkinson's drugs? So the in the periphery, the levodopa will get converted into dopamine by dopa decarboxylase. So that's why, to increase the penetrance of levodopa by increasing the availability of levodopa, we add carbidopa to inhibit the dopa decarboxylase, and entacapone tolcapone to inhibit the COMT enzyme. So whenever you add carbidopa and entacapone tolcapone, the availability of levodopa increases, and then it can cross the blood-brain barrier in a higher amount, and so that levodopa then get converted into dopamine inside the blood-brain barrier, inside the brain, and then it acts on the D1 and D2 receptors. So this patient with the cognitive rigidity, marked facies, and asymmetrical hand tremor has Parkinson's disease, which is caused by the degeneration of the dopaminergic neurons in the substantia nigra, leading to a progressive deficiency of dopamine available to inhibit the basal ganglia. Direct dopamine replacement is impossible because dopamine cannot cross the blood-brain barrier. However, levodopa does cross the blood-brain barrier, where it is taken up by nigrostriatal neurons and converted to therapeutic dopamine by dopa decarboxylase in the brain. And everything else in the slide is whatever I just told you while explaining the figure. So this is the clinical course of Parkinson's disease. So initially, the patient have like a decreasing number of dopaminergic neurons. Initially, the patient will have like autonomic dysfunction, okay, and the patient may have only REM, sleep or behavior disorder. Again, at the middle, when like there is generally 50% to 60% of dopaminergic neurons are lost, the patient will start developing tremor, rigidity, and bradykinesia, and later the patient will have uh, mild cognitive impairment, and in the advanced stage, where there is only 20% of neurons left, and the patient will be having dysphagia, aspiration pneumonia, falls, dementia, and psychosis. Thank you for watching. Keep studying hard.